Hello everyone and welcome to this presentation on neurological signs and symptoms relating to my mind map. Today I will walk you through the key anatomical structures, physiology, neuroplasticity and mechanisms that contribute to movement and rehab. Before I start, what are signs and symptoms? Signs being things we can observe or measure and symptoms being what patient feels or reports. Now let's keep it rolling. The central nervous system plays a critical role in motor control. The cerebrum, our largest brain region, manages higher function like sensory perception, voluntary movement, and emotion. The cerebellum, located at the back of the brain, is essential for coordination, balance, and posture. The prefrontal cortex controls decision-making and impulse regulation, while the hippocampus is key for memory and emotional processing. Finally, the basal ganglia supports habit formation and learning. The brainstem is a critical link between the brain and the spinal cord, responsible for autonomic functions, sensory motor relay, and basic survival mechanisms. From the central nervous system, we move in the peripheral nervous system, which connects the brain and spinal cord to the rest of the body, controlling movement and vital function. It has two divisions: the somatic nervous system for voluntary movement and the autonomic nervous system for autonomic function like heart rate and digestion. An upper motor neuron lesion is damage to the neuron pathway that originates in the brain and travels down to the spinal cord to control voluntary movement. Clinical features are muscles weakness, stiffness, spasticity, and overactive tendon reflexes. For example, a stroke or multiple sclerosis. A lower motor neuron lesion is a disruption in the communication between nerves and muscles, leading to some very specific clinical signs like hypertonia, hyperplexia, and muscle weakness. Over time, lack of nerve input leads to muscle atrophy. Understanding these features is key in diagnosing and managing neuromuscular and neurological conditions. Our sensory system is essential for detecting and processing information. This occurs through specific sensory regions in the brain. When these regions are affected by injury or disease, sensory defects can occur. A sensory neuron is a nerve cell that detects stimulus from an environment and sends a signal to the brain and spinal cord, and then to the spinal cord. Sensory neurons are carriers of our ability to feel, touch, temperature, pain, and body position. Mechanoreceptors help us feel touch, pressure, and vibration. If damaged, like in multiple sclerosis, we might lose fine touch, making daily tasks difficult like buttoning up a shirt. Thermoreceptors sense temperature. Neuroreceptors detect pain, and proprioceptors found in muscles and joints tell us where the body is in space. Diseases like Parkinson's impair this sense, leading to coordination and balance problems. Finally, the vestibular system. When this system is damaged due to disease or injury, it leads to sensory dysfunction affecting both motor control and perception. For example, in a stroke, a person may experience one side of the body has reduced sensation affecting touch and movement control. To understand this, let's touch on reflex arc. What is reflex arc? For example, like touching a hot object. That is the stimulus. This is detected by sensory receptors in the skin. These receptors then send an electrical signal through a sensory neuron straight to the spinal cord. In the spinal cord, the signal is passed to an intraneuron, which acts as a messenger. It quickly connects to the sensory neuron to then a motor neuron. The motor neuron then sends the message to an effector. For this example, the effector is a muscle. And finally, we get a response. Your muscle contracts and pulls away before you even know there's going to be pain coming. Understanding the link between sensory receptors and function is critical for developing treatments. Rehab theories focus on retraining the brain, like neuroplasticity, to help retrain lost function. We'll touch on that later. Now, we investigate motor impairment. We must start with the anatomy and physiology of how a movement occurs. It all starts in the motor cortex. This is where voluntary movement are planned and initiated. From there, the signal travels down the brainstem and the spinal cord. Most of these nerve fibers cross over at the medulla oblongata, which is why the left side of the brain controls the right side of the body. When the signal reaches the spinal cord, upper motor neurons connect with lower motor neurons. These lower motor neurons then leave the spinal cord through nerves traveling all the way to the specific muscle. Motor impairments refer to the limitations in the ability to move and control movements and muscles effectively. Muscle weakness, for instance, a stroke can cause areas of the brain to respond from motor control, leading to weakness or paralysis on one side of the body. Tools like manual muscle testing or functional assessment, such as 5 times sit to stand, are often used to test muscle weakness. Treatment approaches may include electrical stimulation to activate weakened muscles and progressive strength training to rebuild power in the muscle or endurance. Pathologies that can lead to muscle weakness include stroke, multiple sclerosis, and Parkinson's disease. Abnormal muscle coordination are often rigid or stereotypical patterns, often reflected of damage to the central nervous system, are commonly seen in conditions like stroke and Parkinson's disease. For example, after a stroke, a person may experience spasticity in movement patterns that interfere with normal function. To assess these patterns, clinicians may use balance tests or assessments like the BEST. Treatments typically involve functional training aimed at improving real-life performance. For example, being able to button up a shirt or use a knife and fork better, or being able to do them in general. Along with these timing approaches like reaction time and enhance accuracy and smoothness of movement. According to O'Sullivan, Smith, and Fogg, involuntary muscles can appear as tremors, and tics. These disturbances arise due to dysfunction in the communication between the brain and muscles, particularly in the basal ganglia and cerebellum, commonly seen in Parkinson's disease, Huntington's disease, and Tourette's syndrome. To assess these movements, a 9-hole peg test or best balance test can be used. As a result, patients may struggle with daily tasks and the unpredictable nature of movements in general. Abnormalities in muscle tone refers to the change in resting tension of it or resistance of a muscle when they are not actively contracting. This can be present as either hypertonia or hypertonia. Hyper or hyper. Clinically, muscle tone is assessed through observation of range of motion using subjective scales, or passive movement or range of motion, like using a modified Ashford scale, which helps us quantify spasticity and detect abnormal resistance pattern. These tones of abnormality are often linked to conditions like stroke, cerebral palsy, multiple sclerosis, and spinal cord injuries. Cognitive processing is the ability to process, sort, and receive information. Cognitive function is typically assessed using standardized tools like a cognitive log. A loss of cognitive processing, neuroplasticity, and disconnect between sensory input and motor or cognitive output. Cognitive processing is like an effect in, say, your memory. Without accurate perception, even intact sensory inputs can result in functional impairment. Assessments of perception issues often include observation of behavior during tasks, asking a patient to identify parts of their body, seeing if they can. Interventions may include sensory stimulation and tools like mirrors or cues to promote a certain movement and help affected pathways. In motor rehabilitation, neuroplasticity allows the brain to reroute or control movements to healthier areas. For example, after a stroke, if one side of the body is damaged, target therapy can target the side of the body that isn't often used. I want to highlight how neuroplasticity specifically is used in rehab. Aerobic exercise can be used in warm-ups, cool-downs, or in a session. It is an effective way of achieving the release of brain-derived neurotrophic factor. It enhances spasticity and improves cognitive function. Another powerful tool is mirroring, as we spoke about before, to trick the brain into achieving limb and awareness, like sensory awareness. We also focus on task-specific practice. This means practicing real-world tasks. We spoke about this, buttoning up the shirt. All right. We can also limit stronger limbs, which we also spoke about before. This is linked with bilateral training using both hemispheres of the brain, whether it's for a stroke or traumatic brain injury, like Parkinson's, something like this. These strategies tap into neuroplasticity to retrain the brain and help individuals regain movement, speech, or memory. With consistent training, we can rewire the brain and recovery is possible. In summary, I would like to thank you for listening and understanding neurological signs and symptoms along with underlying anatomy and physiology. Thank you.